Good morning, everyone. Welcome to our rescheduled webinar called Why Your Client with SUD Won't Stay Sober Until the Eating Disorder is Treated. I'm coming to you from home today in Santa Barbara instead of the office. We got rescheduled because of a Zoom glitch. So thanks for sticking with us if you are joining us for the second time. I'm going to go ahead and get going, but just wanted to remind you that there's a 5-question poll at the end if you would help C4 out by completing that when we're finished. I only have about 30 minutes of information, and then we'll open it up to questions and answers. So if you could please type the questions as we go. When you're thinking of them, I will get to them at the end, but type it when it's on your mind, and then I'll be happy to answer it later. So I'm Dr. Andrea Kullberg. I'm the Director of Anxiety Experts here in Santa Barbara. We treat severe anxiety disorders, severe panic, social phobia, obsessive compulsive disorder, and eating disorders. I have also been a part of substance use treatment disorder facilities, and so I really enjoy working with the client with SUD. However, it's not a majority of the people I treat. It does happen that with eating disorders, almost 50% of our clients have a concurrent substance use disorder. So we run into it quite often. Remotely, I work for Eating Recovery Center of Denver, and so I'm still involved with eating disorders quite a lot at higher levels of care, in addition to my outpatient practice. The two main types of eating disorder clients in your substance use disorder setting are going to be a low weight patient who might have anorexia nervosa, restricting type, or binge purge type, because of course you have to be unable to maintain an adequate body weight for either of those diagnoses. Or the person might have avoidant restrictive food intake disorder, which, as you may know, is characterized by an avoidance of foods based upon their textures or some fears concerning the foods. Most people with ARFID also have obsessive compulsive disorder, as is true with a majority of people who have anorexia, bulimia as well. The other patient that you might have at your substance use disorder facility, either they come with it or it crops up right after they detox, is the patient who is binging and purging. So the patient with bulimia, which, as you know, for the diagnosis, I have to be using compensatory behaviors once per week minimum. So you're having binge behaviors, overeating in a single sitting, eating much more than an average person would eat, feeling uncomfortably full, feeling a lot of guilt after eating, and then purging through exercise, vomiting, laxative use, etc. And you have to be doing that at least once per week to get the diagnosis. And then binge eating disorder might also come up without compensatory behaviors, without purging, laxative use, or exercise in your facilities. What are the main reasons why clients with eating disorders tend to have difficulty benefiting from substance use disorder treatment? Well, it's because their brain and body are in chronic distress. Not so much the binge eating disorder patient, but the most medically compromised are going to be your anorexia nervosa, binge purge type, and restricting type, and then the people who are actively purging, who are at normal weight, the bulimia patients. In anorexia, the brain is largely offline, so it cannot benefit from all of your wonderful groups and individual therapies in substance use disorder treatment, because the brain is 60% fat, and they might have other metabolic problems. We actually have neuropsychological testing data that documents the cognitive problems in low weight patients, and so they just simply aren't able to process the information from treatment. Their brain is largely offline. And in the bulimic patient, they are experiencing electrolyte imbalances and other metabolic problems because of their binging and purging that keep the body at the edge of all kinds of medical distress, including cardiac arrest or esophageal tears, etc. And so they also have great difficulty benefiting in the substance use disorder setting. Further, the eating disorder is running the person's life choices. So their brain is completely consumed by obsessions and compulsions related to food, weight, shape, or health. I want you to know that eating disorders in the current research have been determined to be obsessive compulsive spectrum illnesses. So the obsessive compulsive spectrum, if you know much about the portion of the diagnostic manual of the DSM, includes OCD and related disorders, and like hoarding, hair pulling, skin picking, etc., the body focused repetitive behaviors, body dysmorphic disorder. And so what we have found in most recent studies in the last 10 years is that anorexia and bulimia in particular are diagnostically indistinguishable from OCD. So the person's entire day is consumed with obsessions about one of three things here on the bottom of your screen: irrational food fears, rigid rules about food, or the body image ideal, which results in compulsive exercise to shape and sculpt the body a certain way, or compulsive checking to try and be sure that the body looks a certain way, and then health anxiety, where we're eliminating more and more foods and products because we're trying to be an ever cleaner eater. We're narrowing the food variety more and more because of fears of health concerns, contaminants, pesticides, whatever it might be. Or we're narrowing the food variety more and more in the case of the ARFID patient because of fears of certain textures of foods, or how certain foods might make a person feel. So it's very rigid rules about foods that way. Either way, the patient becomes very low weight and cannot stay sober. And usually the reason why they started using a substance in the first place is because when you are genetically predisposed to higher levels of anxiety, right? Everybody has anxiety. It's just that a subgroup of people have an anxiety disorder that they're genetically carry the marker for. It might be generalized anxiety. It might be social phobia. It might be panic disorder. It might be obsessive compulsive disorder. But that's going to have many times come on in the brain during early adolescence, or sometimes in childhood. OCD comes on most commonly from 6 to 12 in males and from 8 to 13 in females. And so that's right about the time when it can possibly get stuck on food, weight, or shape, right? The person might have been tapping, touching, counting things, ordering things, etc., before the onset of adolescence within their obsessive compulsive disorder. But then when adolescence comes, they are, or even pre-adolescence, they're at risk for an eating disorder if their OCD ever gets stuck on food, weight, shape, or health. And they start eliminating foods, narrowing their range of what they're going to eat, etc. So they're all at risk for a life-threatening illness. That is very important for you to remember, because even while we're having this webinar for 1 hour, one person will die, as happens every hour in America, from anorexia or bulimia. So these illnesses are very serious matters and need professional treatment. So when the person's obsessive compulsive disorder is coming on in the brain, they might start to use a substance already, or to try and turn off their thoughts, or they might do it later when they feel highly anxious about their eating disorder behavior. So here's how the couple progressions might go. They are having irrational food thoughts. They are concerned about some body image ideal, or they are experiencing health anxiety. And then they might think, oh, I need to lose a few pounds, or I need to stop eating sugars because I need to cut out high fructose corn syrup because it's a contaminant. Or I need to start sculpting my body because I have so few muscles. It might be a male. I am going to begin protein loading and a lot of weightlifting. And so there's the avoidance of certain foods and an overall narrowed food variety, which leads to reduced oral intake and a lot of weight loss over time. And finally, we've got so much increased anxiety from this weight loss and engaging in obsessions and compulsions related to food, weight, or shape that we feel like we have to have something else to shut off our thoughts and deal with our growing anxiety. So we end up using a substance. It's important to remember the way anxiety grows when I'm talking about this. If you've seen any of my other webinars, you know that the job of higher levels of anxiety is to bring on an obsessive thought like, what if I'm fat? Or what if I'm unhealthy? And then it sends a bunch of anxiety, a big surge of nausea, difficulty breathing, heart racing, shakes, numbness and tingling in the extremities, unreality, depersonalization, those kinds of symptoms, all the common symptoms of anxiety. And then it wants you to do one of the three things that lives on. That's what the goal of the OCD or anxiety in general is, to get the person to do one of the three things that lives on. Most usually avoidance, reassurance seeking, or compulsions. So if the anxiety disorder can get the person locked into avoiding a bunch of foods or products, reassurance seeking on the internet about healthier and healthier recipes or foods or better exercises, or compulsions, doing more squats, doing more body checking, doing more weighing, doing more calorie counting, etc., then it lowers anxiety in that moment. However, it feeds the monster in the long run. So the anxiety is bigger and louder once the person starts engaging in those avoidance, reassurance seeking, and compulsive behaviors. So the anxiety is bigger and louder, and the person has a greater number of obsessive thoughts about food, weight, shape, or health, a higher level of anxiety, and greater demand to engage in those same three safety behaviors, as we call them, because they create the illusion of safety, the illusion of certainty, that you're going to be not fat, not unhealthy. And then it reduces anxiety in the moment again when you engage in avoiding another food. No, I'm not going to be vegetarian. Now I'm going to be vegan. Or seek more reassurance on the internet for, all your health symptoms and what else you might eliminate in your diet or your products or your environment to be 100% certain you won't be fat or you won't be unhealthy. And then, of course, again, lowers the anxiety in the moment, but feeds the monster in the long run, so that you have more obsessive thoughts, higher levels of anxiety, and greater demand to do the safety behaviors. And eventually your anxiety gets so high, you truly feel like you can't cope any other way with your nausea, difficulty breathing, shakes, heart racing, numbness and tingling, etc., except to use benzos or pot or something even more potent. So there we go. Another common progression to dual diagnosis is substance use to cope with obsessions and growing anxiety before the onset of the eating disorder. You might have been doing a lot of checking related to rereading and rewriting at school with your OCD before the onset of your eating disorder. Or you might be checking with people you love to make sure nothing bad's going to happen to them, because some of the most common thoughts that OCD gets stuck on are harm thoughts, that either someone you love will be harmed or you will harm someone else. Some of the most common things that OCD gets stuck on are, what if I'm a pedophile? What if I am an axe murderer? What if I could do something to harm someone? What if I'm treating someone right now who's afraid she's going to harm other people's property. So she's going to, damage a public restroom. She's going to kick a car when she walks by it. Maybe she's going to deface a religious object or something, and be accused of something terrible later by the police or whatever. So there's no end to what OCD can get stuck on, to take the person's time up trying to get 100% certainty that they aren't going to have something bad happen or do something bad themselves. So someone might already in their adolescence or either early adolescence or early adulthood be starting to use a substance to cope with their growing anxiety from all the compulsions they're doing that aren't related to food, weight, shape, or health. But eventually they might get stuck on something new related to food, weight, shape, or health. And then, or they might think, I can't eat because I'm so nauseous, I'm having heart racing, difficulty breathing, etc. So they eat less, even on accident, because they are so distressed. And they're using this substance that doesn't allow them to be present with their body sensations or their hunger cues. And so they start to avoid food. They have a narrowed food variety, reduced oral intake, and the weight loss and metabolic imbalances. Maybe they're reducing their oral intake by purging in their mind. So that could be another. They might not just be eating less food, they might be binging and purging. And so then you've got the substance use disorder preceding the onset of the eating disorder. But either way, when you've got them both occurring together, you're in trouble, because the patient with OCD is not really going to be able to stay sober once they're using the substance along with their eating disorder. They come back over and over and over again. You got all these low weight patients in substance use disorder facilities, or patients who are binging and purging. And the prevailing belief is we have to treat the substance use disorder till before the person can benefit from eating disorder treatment. And I would argue that the eating disorder really has to come first. Of course, they're going to be in residential treatment where they can't use a substance as well, but it isn't until their brain comes back online that they're really going to get the most out of the substance use disorder treatment. So what we usually have, what we had in, at least in the last substance use disorder facility I worked in, last year was when I was working there, is multiple courses of substance use disorder treatment with no hope of sobriety. The client considers themselves to be a failure because they're going in and out of all these different levels of care and facilities, but their anxiety is so high and it's going untreated. And so they just feel like they cannot do without this substance because, again, even though anxiety is always temporary and harmless, when it's present, it is so uncomfortable. The nausea, the shallow breathing, feeling like you can't get your next breath, even though no amount of anxiety can be dangerous to someone, it can never harm anyone, but it just feels so uncomfortable. The person believes firmly that they have to have this substance. So they consider themselves to be a failure because, I think I have to have this thing. And then they're labeled by treatment teams many times as treatment resistant or as having a personality disorder, when really what they have is OCD, stuck on food, weight, shape, or health. So what is the solution? Well, what I'm suggesting is that the person be detoxed at a substance use disorder facility if needed, and then that they be sent to residential eating disorder treatment, followed by an eating disorder PHP, IOP levels of care, preferably while they are in sober living, and then substance use disorder treatment, preferably while they're in sober living. Because again, they're going to have to be held accountable to their meal plan with an outpatient eating disorders team so that they can maintain their weight that they've gotten to in the eating disorder program while they are undergoing their substance use disorder treatment. Or another way after detox, if needed, would be to admit to a residential eating disorder treatment with a substance use disorder track. Sometimes you have, like at Eating Recovery Center of Denver's program, they have a substance use disorder track on some of their units, And so half the patients are in that track, half the patients are in the sober track, and they've got specialized groups and individual therapists and family therapists who are addressing those issues within the individual and family while the patient is there. They might be going to meetings, etc. They also have, Eating Recovery Center also has units that have eating disorder or substance use disorder tracks in the Chicago location. So if you investigate eating disorder facilities thoroughly before you send your patient, you'll know if they have a substance use disorder track or not. And then they can go to PHP, IOP, eating disorder treatment, usually at the same facility. Like Eating Recovery Center has all levels of care, and you're required to be sober in any of their supervised apartments or unsupervised apartments that are connected with their programs. You're regularly tested, and you are living with within a sober community. If not there, then you can be in some type of sober living house or something while you're attending the PHP and IOP levels of care. So you say, well, why do we have to do this? Why can't we just do the eating disorder treatment ourselves while they're at our substance use disorder facility? And the reason is because eating disorder treatment is highly specialized. It's based on specialized knowledge, with where the physicians are specially trained and the therapists are specially trained. For example, did you know that if a person is underweight 10 or 15 pounds for an extended period, and especially if they're missing their menses, they are losing bone density that entire time. And so they are at risk for lots of health complications, including bone density loss, when they are low weight for an extended period and going in and out of substance use disorder treatment facilities with their eating disorder. So at the eating disorder facility, they will have a DEXA scan, a bone density scan, and come to understand why they need to get to and maintain a normal weight. Also, not only does low weight kill people, but as I mentioned earlier, anorexia can kill people because of cardiac failure, etc. 1 person per hour dies from anorexia or bulimia, but of course purging kills. So we've got many people who are dying each day in America from vomiting and laxative abuse and compulsive exercise. So these are very dangerous illnesses and need to be treated by specialized professionals. Weight restoration is also necessary in a medical environment because when you have a patient below a certain weight, they are at risk for refeeding syndrome. You may have heard that when they refed concentration camp victims too quickly after the concentration camps were freed at the end of World War II, that they killed many people. And this was because nothing was known yet about refeeding syndrome. And so someone's blood tests have to be done every day or every couple days. Whenever they get a meal plan increase, they very slowly increase the meal plan, the registered dietitians at the eating disorder facilities, to avoid refeeding syndrome. So they can only put on a certain amount of weight safely on a patient, 2 to 4 pounds per week at a residential eating disorder treatment, because they are dealing with this refeeding syndrome issue. Plus you can overwhelm the liver and heart and other organs if you put weight on a person too fast, or turn on illnesses in their body that you don't want to turn on. Also, a prescription meal plan is required. So in the eating disorder treatment environment, the reason it has to be done professionally is because people with a master's degree in nutrition, registered dietitians, who are the only people licensed to do medical nutrition management, are there at those facilities. So anyone can call themselves a nutritionist. Anyone can take a seminar and put their little shingle up and say, I'm a nutritionist. But they are not registered dietitians. They are not medically trained to provide sound nutrition advice that is the standard of practice in our healthcare system today. The other thing that we're doing in eating disorder treatment facilities is interrupting eating disorder behaviors. So the reason why someone can't stay in a substance use disorder facility who is binging and purging is because they will have access to bathrooms at all times of the day normally, or can purge outside, or they will make their own food choices and never stop eating the narrow range of food that is diminishing their health. So in an eating disorder facility, bathroom times are scheduled every 2 hours and roughly, and they are also right before meal and snack times, so that the patients can have their behaviors interrupted. They experience the thought, I have to purge, I have to get rid of this food, it's making me unhealthy, it's making me fat. They have a surge of anxiety, and then they aren't allowed to engage in the compulsion of purging, the compensatory behavior of exercise. They are not allowed to exercise on an eating disorder unit while they're weight restoring, at least. And the only engagement in movement they might be allowed to engage in is gentle stretching that is supervised, and after which they may even have to supplement with some type of snack to account for the nutrition they expended while they were doing their movement. Sometimes on an eating disorder unit, a patient who has a lot of compulsive pacing and other movements will be put on an actigraph where their steps are measured. It's kind of like a Fitbit, a high-tech Fitbit, and then they will be supplemented for the amount of movement that they're doing, and that reduces their movement significantly. I've seen people become, scores of people become totally free of their compulsive movement on eating disorder units, and then those compulsions are completely interrupted. Also on the eating disorder unit, the choices in food are made for the patient, so they sit down and they don't know what they're going to eat most of the time until they're ready to have a few more choices in their menu and their meal planning with their dietitian. So they are exposed to all those foods that they've been avoiding that have been growing their anxiety, making them worse. Each thing you avoid with anxiety makes you worse. So if you, regardless of what you're avoiding, so if you're in a car accident and you start to avoid driving, you will drive your anxiety up because you're telling the body and mind that your thoughts about accidents are dangerous, and your driving might be a dangerous activity now. That's what you're confirming for the body and mind, so the anxiety will go up. Whereas if you have gotten in an accident, you have the thought, maybe I'll get in an accident, and you have anxiety, and you tell yourself, it's true, I'm going to be taking the risk of getting in an accident again by driving. And then you don't avoid driving, then your anxiety will go down each time you drive. So anxiety lives on. It can't be overemphasized. Anxiety lives on avoidance, reassurance seeking, and compulsions, okay? So lastly, I want to emphasize that the reason to send someone to eating disorder treatment and have them come back to SUD treatment is because full weight restoration for the underweight patient is the #1 predictor for long-term recovery. So we're just talking about anorexia restricting type, or binge purge type, or avoidant restrictive food intake disorder here. But the patient getting to their healthy weight that they were at before their eating disorder, or the healthy weight calculated by a dietitian if they had their eating disorder come on when they were 14 and they've never been a healthy weight since then, the dietitian will calculate a healthy weight based on their extensive knowledge and scientific markers. And that is the weight the patient needs to trust and get to in order to have the best chance for long-term recovery. The other last thing the patient needs is medication stabilization. So there's the Behavior Therapy Training Institute courses for psychiatrists that they can, at the International OCD Foundation, that they can take advantage of. And that is where psychiatrists can learn to best medicate obsessive compulsive disorder and other related disorders. Severe panic, severe social phobia is at those trainings. And it turns out that the #1 treatment course for someone with these disorders is a single SSRI at 2 to 3 times the dose that is recommended for depression. So, for example, one of the things that Dr. Michael Janicki of the Harvard OCD Institute teaches the physicians in the trainings is to ramp the patient up to, let's say, 150 to 200 milligrams of Zoloft, and then the patient has to stay on it for 10 to 12 weeks in order to know if they're a good responder. And the OCD Foundation recommends 3 different trials of SSRIs before you try to add any other medications to the medication regimen. And so that means it takes 3 months to try an SSRI sometimes, because you're slowly ramping up to, let's say, 60 to 80 milligrams of Prozac. And then you're staying on that for 10 to 12 weeks in order to know if you're a good responder to it or not, before you might go down on that and cross titrate onto Lexapro or something and as a second trial if you weren't a good responder to the Prozac, for example. So anyway, it's a specialized area of medicating, and not a lot of psychiatrists are familiar with it. The most usual course of treatment in my experience, and I'm not a physician, but is to put someone on a lower dose of 20 to 40 milligrams of something like Prozac, let's say, and then adding a mood stabilizer or an antipsychotic or something like that for the patient's severe anxiety. And the psychiatrists learn alternative ways of medicating at the BTTI trainings. So, well, where are you going to put your patient in eating disorder treatment? How will you know if they need PHP, IOP, or residential, really? And this is just a little chart you can maybe reference later. It talks about how if the person is above 80% of their ideal body weight, that you can refer them to partial hospitalization, whereas if they are either less than 85% or they are above 85%, but they need a lot of structure in order to interrupt their behaviors, such as binging, purging, compulsive exercise, laxative use, etc., they might need residential. Of course, because if they're bulimic, they will be at or above a normal body weight, but they will require the structure of a residential environment to interrupt their behaviors. So this just discusses all the different needs. Of course, they will need inpatient or residential level of care if they are very low weight and require a tube feed, et cetera, which will be determined by their treatment team at residential level of care. Usually, many places will have inpatient and residential on the same unit so that the patient can step from one level to the other. At least they do at Eating Recovery Center, for whom I work remotely. So I think that was it. That was the basic gist of where you might refer your client. Now I'd like to go into a discussion so I can answer some of your questions. Let's see. I've got my question box open, but I'm not really seeing anything in it yet. I'm wondering if I'm missing out. Jesse, do you think I've missed out on the my helper, Jesse?
No, it
Okay.
just looks like there aren't any questions yet.
Okay, gotcha. So what do you guys have for questions? I want to speak to specific issues that you might have with your clients, specific questions you had about what I said. I know one of the things that often comes up is that people think, well, what is the approach that they're going to get in terms of therapy when they go to an eating disorder facility? And there's really 2 types of therapeutic approaches at the eating disorder facility. One is whatever the primary therapist is doing, and the other is the milieu. So the structure of the actual milieu is what interrupts the behaviors. Much like a substance use disorder facility, the person can't engage in the behavior if you are there holding them accountable and preventing them from using. Same thing with the eating disorder patient. So it's the milieu, it's the interruption of behaviors by not having access to bathrooms, by not being able to choose what you eat. But the primary therapist is also working on, we hope, some types of exposure therapy for the anxiety, helping the patient learn that their anxiety isn't dangerous, that it cannot harm them, and that they can learn to tolerate the surge of anxiety without engaging in behaviors, that they can learn that it will rise, it will fall, and that the faster that they invite it to intensify, the more quickly that they will be on the downward slope of the surge of anxiety, and learn how to ride the wave of the anxiety instead of engage in avoidance, reassurance seeking, or compulsions. I got one question here. Oh, what is a specific amount of exercise that's considered to be excessive and as a form of purging? So this is, of course, debated hotly, and we live in a culture where it can be normalized to exercise 6-7 days a week, and people are praised for compulsive fitness, and so that is sad. But the medical recommendations are 3 to 4 days per week of 30 to 60 minutes of cardiovascular exercise. And so we talk about exercise in moderation in eating disorder treatment, but we also work with athletes, and so we have to adjust our treatment for people who want to either continue in their athletics or in a healthy manner, or take a break and then go back to athletics in a healthy manner. I have had patients who stop their ballet and don't go back to it for a year. I've had patients who stop their soccer for 3 months or 6 months and don't go back to it. We do want somebody to stop exercising if they're weight restoring, stop exercising entirely while they're weight restoring. Like I said, except maybe some gentle stretching on the eating disorder unit that's supervised, and where they might supplement after. Their meal plan will account for it. But after eating disorder treatment or after weight restoration, and even during eating disorder treatment, if someone's at PHP level of care and they are someone who binges and purges, and maybe they are a runner and running is not part of their eating disorder, they might be allowed to keep running at a certain amount, and if they are willing to supplement their meal plan, eat this certain amount prescribed by the dietitian after each time they exercise. But that's more unusual. It's pretty common that exercise is a part of the person's eating disorder, that they're using the exercise as a compensatory behavior to get rid of calories, to shape their body, to decontaminate, etc. And so they're asked to take a period off of exercise and then reincorporate exercise slowly in a healthy way if they can show that they can supplement for the activity, add to their meal plan for the activity, and maintain their weight and not return to behaviors. So sometimes, let's say a 16-year-old comes out of residential back to my private practice. Her parents are supervising all of her meals and snacks. They come to the school and supervise her lunch so that she can't skip any meals or hide any food. And then 4 to 6 months later, they say, okay, you can go back to ballet now, and we're going to supplement this much after the activity. So each time you come out of ballet class, let's say they go back to ballet 2 days a week, 3 days a week or something. And then the patient is exercising in her room at night. She's caught exercising in her room after bedtime or something after she gets back into ballet. Oops, we went back into ballet too early. So we're going to pull back on that, go back to our artistic pursuits or something else. And we're not going to try that again for 6 months. We're going to keep supervising the meal plan and maintaining our weight. Because again, if the patient starts dropping weight due to the resumption of exercise, which is the number one reason why they might relapse, is the resumption of exercise too early and the related weight loss, then they're just back in their eating disorder, okay? So when you have a target weight that the person has been put at, so if 130 pounds is your target weight and you're at 130, you're going to fluctuate 135 to 125 all month long, like an average person might fluctuate 5 pounds up or down at any time. But once you get below that 5 pound mark, below five pounds from your target weight, so once you're below 125, you're in the vortex of the eating disorder in your mind. You are thinking about food all the time, because nobody thinks about food more than someone who is malnourished. So once you start that process, the body's like, oh no, she's going to restrict again. I've got to make sure that I secure some food here. She's going to send me into a famine again, or he is going to send me into another famine. So the body is just consumed, and the mind is just consumed with foods. And sometimes if you are intent on losing weight, it'll be all kinds of obsessions about dieting again and what foods you can cut out, and they just kind of spiral down back into more and more weight loss or binging and purging. So yeah, did that answer the question? I hope that helped. What else you got? Oh, good. Yeah, these things are pretty complicated in terms of the individualizing of the treatment plan, I guess, for the patient a lot of times. So other questions about eating disorder treatment or the treatment of anxiety, the exposure therapy process. For those of you who don't know, the #1 empirically derived treatment for the entire anxiety spectrum is exposure with response prevention. And that's basically what we're doing in eating disorder treatment. We're doing live exposures, and if the therapist is good, they're doing imaginal exposures. So the exposure with response prevention therapy involves 2 types of exposure tasks. One is the live exposures, where we go into situations that are anxiety producing for us on purpose. After we learn that anxiety is harmless, gotta learn all about how no matter how high your anxiety goes, it can't hurt you. And no matter what negative thoughts you're having, they can't harm you, and then there's no need to obey them. So after the person learns about the basic principles of exposure therapy, then we slowly reintroduce them to all the foods they've been avoiding and all the situations they've been avoiding, eating in a group, eating at restaurants, eating with their family, all those situations. And then the imaginal exposures are really inviting thoughts on purpose that maybe I'll be fat, maybe I'll be unhealthy, there's no way to be 100% certain, I can't have the certainty I seek. OCD can never be certain, it can never get to the place it wants to be, because no human can have certainty about anything in life, right? And so maybe I'll be fat, maybe not. I'm going to eat these foods and see how it turns out. Maybe I'll be sick from this food. Maybe I won't be able to tolerate it, right? I hear every week, I don't think my body can process meats anymore. I don't think we can introduce that yet, right? No, I don't think, no, you don't understand. I have, a gluten and a corn and a soy allergy, and I can't take these foods. Well, you ate those foods from the time you were born till the time you were 15, and we're just going to assume that this is your OCD and your eating disorder and not the truth. And we're going to introduce these foods one at a time and see how it turns out. And we have to agree with thoughts that maybe you will get sick, maybe not. There's no way to know. We're just going to assume that this is a part of your eating disorder and resume eating normally as best we can. So those are the imaginal exposures, where we're agreeing with thoughts on purpose that something bad might happen, just like we go into situations on purpose that where we're embracing uncertainties. Because that's the problem with anxiety. The whole anxiety spectrum, the farther you are along the anxiety continuum, the more difficulty you have living with uncertainties. So you've got simple phobias as the most mild end of the anxiety spectrum, which is 1 in 10 people have a simple phobia. Then you've got generalized anxiety as we move along the continuum, which is characterized by excessive worry. You've got maybe social phobia, panic in social situations, or panic disorder. Then at the end of the continuum, you've got OCD and the eating disorders, where we've got the highest levels of anxiety and the greatest difficulty living with uncertainty. The problem is wanting a thing that no one else can have, which is 100% certainty that you're not going to be fat or that you're not going to get sick. And so all these compulsions and avoidance behaviors and reassurance seeking to try and get a thing, again, that no one else can have. You never arrive there, so there's never healthy enough. There's never the elimination of enough foods. And so the eating disorder wants you to keep going with your binging and purging, keep going with your elimination of more foods and even fluids until you die. And so that is why many patients have to be treated for eating disorders against their will. At Eating Recovery Center on our units, we have at any one time many patients who are on certifications and mandatory holds because they have to be put into treatment against their will until their brain is back online and their body is healthier, then they can make decisions for themselves again. But when the brain is below a certain weight, especially, it cannot make proper choices. We cannot leave the eating disorder treatment up to the patient below a certain weight because they aren't capable of making those choices. So I'm not sure how much time I have left. Jesse, do you want to check in here and let me know how much time?
Looks like we've got about 7 minutes.
All righty. Any other questions you guys have? I know this is a difficult time of day to show up, so at least on Pacific time. So thanks for coming. I know it's later for those of you on the beautiful East Coast. Well, I think that's about all I've got. So I'll let you all go. And again, if you don't mind filling out the 5-question poll at the end, we greatly appreciate it. And please don't hesitate to write to me at amkulberg@msn.com, or you can go to my website, andreakulberg.com. If you email me, or I will answer your questions about a client. I'm happy to communicate with you about specific questions you have about clients. Also, Jesse tells me that he will send out the slides so that you can have those to reference. And thanks again for joining us. Take care.